Hello, class. This is Randy Gaines checking in. And I believe we are supposed to be talking about this video we had to watch on TED Talk on in the transgender community. Compare and contrast the information from week 3 on hate crimes and TED Talk on respect. Um, so what we the references will be made from the American Nurses Association Code of Ethics for Nurses Interpretive Statements, the Nursing Social Policy Statement, 2017, and from the video itself, which is the Why Are Many Doctors Scared of Transgender? I'm sure it has a longer title, but that's what it is. So, had a hard time watching this video, and here's why. So I watched the video and I heard what the doctor was saying, and I hear it. However, I'm a psych nurse now. I have an undergraduate degree in psychology, and there's nowhere in nursing or healthcare at all where it says that we're supposed to, or let me take drawback. We are supposed to help people in their time of need. We are supposed to help them address their emotional concerns, their physical concerns, and so on and so forth. Where I disagree with the doctor is the transgender population is putting us in a strange position. People that are probably as old as I am or older, transgender. Well, at one point in time, being homosexual was considered a mental disorder, but that got updated, and for good reason, because it's a sexual orientation. If you feel like being with a man or a woman, that should not and does not make me feel any better about your actual treatment at the hospital. Like, as a matter of fact, it doesn't help me do my job whatsoever. I don't care. I don't want to know. No different from a heterosexual. I don't treat you any different um, because you want to be with a woman. Or to me, I can't even think of many people that I know that kind of have an issue with you being lesbian or gay or whatever, because it doesn't help us do our job. Um, and let's see. Our provision one, the nature of health, nurses respect the dignity and rights of all human beings, regardless of factors contributing to the person's health status. The worth of a person is not affected by illness, ability, socioeconomic status, functional status, or proximity to death. So, that being said, as long as we are aligning with the my care does not change because of a sexual preference. No difference does it change if he's black, he's white, he's Asian. I don't think any of those factors should make a difference. Where the transgender throws me off at is it's not even a religious thing. It's a you are biologically, like, either you have a penis or you don't. So I know that seems very basic, but that's just where it is for me. It, as a clinician and a psych person in general, um, when I have to address somebody that is obviously a male as a female, and we're so now we're saying we're not males and females, and we're we're just assigned a sex, a biological sex, as opposed to what we feel like. I I can't do it. It's just one of those weird things. No different from when I'm treating the anorexic. She can be super bony, like all skin, all bones. I can see them swallow. I can. We still address that as a medical condition because the body dysmorphic disease. To me, the transgender stuff is the same. you are wanting me to physically look at something, or you want me to keep telling you you're a woman when you're not a woman. And we were taught in school that we don't reinforce delusions. And to me, that's a pretty big delusion. Um, and even when we do it, a lot of the times, I don't know what your guys' experience is with it. I actually have to deal with it a lot. And sometimes it's very upsetting even to the other patients because it's like, okay, this person is clearly a male. Everything about them is male except for maybe they grew their hair out. But they still have the tone of a male. They still have the body of a male. They're just saying, hey, call me Sheila. And everybody's trying to address you as Sheila and or whatever. And it's like I think we've taken this a step too far. And again, this is my opinion. This is not whatever. Um, I think it is very hard for most clinicians to. How am I supposed to be addressing female issues with a male that's never going to have the problem? The only way you're going to have it is in your head. So to try to differentiate a psychiatric condition, and we keep trying to make it, a actual, oh well, no, it's just an identification. It's not just the identification. You, you are a male or you are a female. Now, if you feel differently, then you can actually sit down and talk to people about that. And then if you're really committed to it and have the sexual reassignment surgeries and all that stuff, well, then now you're technically not that person anymore. Now, genetically, you're still the same. And per your genitalia, you're different. I don't think we have a good way to address this yet. We just don't. We don't even know what unit we can send people to now because it's becoming such an issue. It's like people have to have their own unit because I can't send them to somewhere this well, I'm identifying as female. Okay. So if I send you to a place that actually has the units divided by sex, which some still do, um, if they have a history of sexual abuse and then I send a man in there, even though the man is identifying as a woman, the woman doesn't see your identification. The woman sees the man that assaulted him now is in here with the rest of us. I don't like it. So you're actually, to me, infringing on other people's rights when pushing so hard to push them on the other people. And I think we're gonna have to, if we just must like absolutely address it, that's fine. However, I think there is a difference in transgender versus being lesbian, being gay, being black, white, Chinese. This is something that's gonna take more looking at, but as it stands right now, it's just one of those kind of anonymous things that's going on with healthcare because in all actuality I really don't feel like we should be a your sexual whatever has zero to do with the effectiveness of me doing my job. I almost wish we could just stop talking about it because it makes everybody look crazy one way or the other because now we're coming up with this CIS stuff and it's like I don't know. I can't describe it differently than that. It just seems like everybody's just making up their own rules and then we're supposed to go with it. And it's like if we're the medical professionals, we need to do a better job of addressing our populations as opposed to letting everybody tell us what we're gonna do when it comes to that. Um, as as what she was saying and relating to the case from last week with the teenager that got beat to death. I kind of don't get the connection. Um because I really do think it's two different issues. If somebody got beat to death because they were gay, that's wrong. I don't think anybody would disagree with that. And but treatment as in, oh, well, I'm transgender and I want you to call me whatever, that's different. That's a completely different extreme as far as I'm concerned, because I don't think anyone should be um grossly discriminated against or beaten or killed because of their personal choices. I just don't believe that. I don't think many people believe that. So I think those are two kind of different extremes. Is even though they're two points in the LGB um, alphabet, it's not the same. So I think those were two separate entities and choices that were made. But I think that as long as we are in nursing or healthcare, the end game is that we should just stop asking people about their sexual identities and everything else and treat what they're there for. If they're having a heart attack, let's talk about the heart attack. If they're having a stroke, you got it. Talk about the stroke. I don't see how your sexual whatever, now of course with the psychosocial stuff that does, but that's a different thing altogether. If we're gonna add the psychological component, that's why I think most of them should be in counseling, because um one of the studies that I looked at, or it was a I'm sorry, give me a second. There was a doctor from Johns Hopkins, and I'll add it in there, that actually studies transgender. His name is Paul McCullough, and he actually has done several studies on them and had for years. He's like one of the authorities, and he is even saying that there's a higher incidence in suicides and even after people have sexual reassignment surgeries. So if it was just as simple as, okay, we're going to fix the parts, it still didn't fix the parts. They're still having psychological issues at a higher rate. So it's not about even just switching it. There's some underlying things. But their health concerns, are they having a heart attack? Do they have diabetes? Let's fix all of that. And then when it comes to their psychological stuff, they should be talking to people as opposed to people just saying, oh, this is completely normal. There's nothing wrong with it. And everybody else needs to change something, because I don't think that's correct. So that's my little piece of the information for tonight. So hope y'all have a good night.